injuries. If you guys have any questions about anything as we go through this, please Phil just stop me in between. Just trying to cover a lot of different stuff and give you guys some ideas on what's out there and how you can approach it, and especially how when to send stuff to us. So obviously hands and fingers being out in the world, they're one of the most commonly injured parts of the musculoskeletal system. About 10% of all fractures are phalanx fractures of your fingers. Fingertip injuries are very commonly, probably the most common seen hand injury in the emergency department, and they're often missed. And that's part of the reason we're giving this talk, is that in the peer review committee there's a number of patients who have been reviewed because they haven't been managed maybe quite as well as they could have been, and we kind of wanted to see what we can do to maybe stay on top of that a little bit better. So we'll start with some hand and finger trauma. There's just kind of a lot of different things just to talk about to give you guys some ideas about things. So we'll start with what's called a mallet finger. This is an extensive tendon rupture of your distal phalanx. It can either be, as you can see in this little white picture here, it can either be the tendon, or you can actually pull a little piece of bone off like there. This is a lot of times what it looks like, where the tip of the finger will kind of fall down. Can I turn off the lights just here?
You know, you can, but it really darkens it up here.
So the treatment of this is a stack splint in most all of the cases. The big thing about that is, and we have them in ortho, it's something you can certainly get in the primary care office too. The biggest thing is, in the stack splint for 6 weeks, do not bend the finger, period, for 6 weeks. The hand surgeons I talked to say you bend it one time in 6 weeks, you got to start over again to allow that to heal. So it's very important that just leave it straight. Sometimes it requires surgery if the whole phalanx, or the big enough piece is broken off that the phalanx is now starting to fall down. Sometimes it does need surgery. If there's more than 50% of the articular surface is broken, or if there's more than a 2 millimeter gap, sometimes they do need to go to a hand surgeon to be fixed, but that's uncommon. Most mallet finger injuries are tendon ruptures, and they heal if you put them in a stack splint, but you have to actually follow it pretty closely to get it to heal. If not, you kind of have a chronic downward angle of your finger, which is the end of the world. I know a very good hand surgeon who has a mallet finger that never healed properly, and he still does hand surgery and plastic surgery with a mallet finger, but it's kind of unsightly. Phalanx fracture is another kind of common thing that we see, like we talked about. A very common injury, 10% of fractures, but more common in males than in females. Usually distal phalanx, middle phalanx, proximal phalanx. Small fingers very commonly affected, and these can be anywhere from a very simple fracture to quite a complex fracture. So starting with, first important thing is get good x-rays of these things. One x-ray, they always say, is no views, so have 2 or 3 views. You can see on this one, I don't know how easy it is to see here, but that finger doesn't look that bad. When you look at there, it's a little bit off, but if you look at this one, you can see it's 100% displaced. Same thing here. That fracture does not look bad there. You look here and you can see it's actually articular. It's off quite a bit. It needed 2 screws. So just make sure when you're taking pictures of fingers, or of anything for that matter, take 2 or 3 views of it. Don't just get one. Starting with stable fractures, you can see this. There's a little fracture here at the proximal phalanx of the small finger. It's non-displaced. It's fine. You know, we talk about if they're extra-articular, if they don't have a lot of angulation, don't have a lot of shortening, and there's no rotational deformity, you can buddy tape the fingers together for about 3 weeks and then get them in early motion. Moving on, this is a little bit worse one now. They call this extra-octave fracture because you almost can get an extra octave with your finger. You can see how the 5th phalanx sticks out here more. And it's a fracture a lot of times through the growth plate in younger kids, and the finger can stick out quite a bit. The 5th finger is displaced quite a bit. It needs to be seen in ortho pretty urgently, like the day of the injury, or maybe the next day, or as soon as possible, because it needs to be reduced and splinted. And then these kids usually do pretty well. It happens most commonly in someone younger, but if they don't get reduced quickly, they heal pretty quick. So get them into us soon. As we move up now, we're going to look into oblique or more displaced fractures. A lot of these do need octave fixation. Sometimes we put screws in them, plates, at least reduced. Biggest thing, they need to be splinted properly, and always splint past the fingers before they're sent to orthopedics. That's a big problem we have, is the way the splints are placed. We'll talk about that a little bit later. Now, when they become intra-articular, you can see these that into the joint. These are pretty bad fractures. A lot of times these need to go to a hand surgeon. A lot of times we don't fix them. So the big thing with this is if you see a bad fracture, call us first. and talk to us, because we might want to just have the patient go to see the hand surgeon right away, and if you make an appointment with us, but don't tell us, and then it's a couple, 4 or 5 days when they see us, and then we finally see them, then they go to the hand surgeon, and it's a couple more days when they see the hand surgeon. Before you know it, they have a couple weeks of delay in their treatment, and that isn't as good. So if you have a bad fracture, before you just send the patient to orthopedics or the referral, maybe call one of us. We can talk to you about it, look at the x-ray and say, what, let's just skip sending one to us, we'll get them to the hand surgeon right away. It saves us a lot of time, and it's way better for the patient. So, tough fractures now on the other end of things, it's a crush injury at the end of the finger. They're usually pretty stable because of the nail and all of the connective tissue that's in your finger. A lot of times, if the fracture is stable and there isn't a terrible injury to the finger, they can just be splinted in a safe position and allowed to heal. If it's an open fracture, I'm going to treat them like an open fracture, and then also a lot of times with nail bit injuries, which is the next thing we're going to talk about. It's a little bit more of this fingertip. So a big thing with this probably more applies to the emergency department than your primary care office, but a big thing is how much, even when people cut off the end of their finger through the lawnmower or the saw or whatever, how much bone is exposed. If there's less than a centimeter of exposed bone, now the hand surgeons have you put a ton of bacitracin on them, like an excessive amount, and put them in a dressing and let them heal. They've actually found that they will heal neurovascularly better, they'll have a more functional finger, more sensation, and will do much better if you just allow the body to heal it by secondary intention. It takes quite a bit of time, but instead of doing these flaps and advancing and all that kind of stuff, they actually do better with that. So now we're doing a lot of these things. The biggest thing is a lot of petroleum ointment with help with the dressing changes. A lot of these patients come in after they had a dressing placed somewhere, and it was put on, and it dries, and it sticks to the blood, and then we're trying to soak them off, and it's awful for the patient. So make them excessively greasy, and then the dressings come off a lot easier. It's way easier on the patient and on us. So, but again, give us a call. We'll help you with that. Open fractures. Antibiotics are a very big thing with these. Anytime you have communication of the fracture, you see a fracture and there's a laceration, it's open. The biggest thing is they need to get a gram of IV antibiotics basically right away. Start with the first generation cephalosporin, or you can use Clendo or Vanco if they've got a penicillin allergy. And this is a little bit more for the emergency department. As the wounds get bigger, they need more antibiotics. But the biggest thing is if you can give them within an hour of the injury, it's best. If you're in the emergency department or they come into your clinic, give them a gram of IV antibiotics and then call us. Because they've found that's the one most important thing for preventing infections and osteomyelitis, getting that antibiotic in as soon as possible. So that's the biggest thing with that. Many, many, many times I get a call from the emergency department with an open fracture. I'm like, did you give them antibiotics? And no. So first step, give them antibiotics, then call us. Tetanus prophylaxis is good too. Wound needs to be washed up very thoroughly with 1 to 3 liters of fluid and then splinted. One of these nail bed injuries, you can see this one, it's harder to see here, but just a lot of blood underneath the nail. Obviously this one is a little bit more clear, and so is that one. The nail, the important thing with that is this eponychium, or the cuticle here, needs to be held open with something when they're repaired. You can see here where the end of the nail has come out of the underneath of that nail fold, and that needs to go back in there. If the nail fold can heal closed, and then they won't grow the nail back, and it can create a lot of problems if that nail fold is held open and they're allowed to heal. The new nail will grow out, it'll come out pretty nicely. I had a case that I saw where they actually sewed the nail fold closed with a nail bed injury, and we had to take it out and take it in the operating room and do a lot of things. You can clean and reuse the old nail, you can put foil foam suture packing in there, you can put some adapting in it, just don't sew it closed. And just know that if you have an injury to the nail bed, a lot of times I can lead to deformities of the nail plate and funny looking nails going forward from there. Another type of fracture we see a lot is this boxer's fracture. I'm sure many of you have seen this too. A lot of times we can accept quite a bit of angulation in the fifth, but a lot of times they need a little bit of a closed reduction in casting, so get them to us sooner than later, but just to kind of show you what a boxer's fracture looks like. Metacarpal fractures, now doing into the hand. Biggest thing about this is properly splinting these. We've had a lot of patients come to us with a cock-up wrist splint, and so they have a break in their hand, and they put them in a cock-up wrist splint that ends at the fracture. It's about the worst thing you can possibly do with it, because now you create a stable fulcrum right at the fracture site. So if you're going to splint someone, it's like this. You need to splint the joint above and below, put it out distally, Also, safe position, we'll talk about that a little bit, which is what this looks like, a little bit of angulation in the hand. I have another slide on that, but please do not put these metacarpal fractures in just a cock-up wristment. They have to be put in the orthoplast, split past the area of injury to hold it stable. This is what they're called the safe position of the hand. The biggest thing is a little bit of flexion of the fingers. Don't splint them completely straight in the fingers. They'll have terribly stiff fingers, and it'll take months to get them back to function in their fingers. So the biggest thing is a little bit of extension of the wrist is good. The biggest thing though is a fair amount of flexion at your MCP joints here, as you can see there. And the fingers can be in full extension or a little bit of bent. I know the hamstrings always talk about the beer cam position. If you just kind of like make a fist and then let your hand relax, it sort of has a little bit of a curve to it. That's okay too, or the fingers straight, but definitely some bend at the metacarpal phalanges when you're splinting somebody. Another big thing we have a lot of problem with is flexor tendon injuries. We've had a number of these that have gotten missed, that didn't get diagnosed properly, and got sent to a hand surgeon late, and that's a problem. So, flexor tendons, there's two. There's a flexor digitorum superficialis, which is here. It attaches to your middle phalanx, and then the profundus goes through and attaches to your distal phalanx. We need to check the function of both of them to really be able to say that there's not. We've had a number of patients that came to see us weeks later where they said there was no tendon injury and they had a tendon injury, so obviously it didn't get checked properly. An exam is important. It's kind of a detailed exam to examine a hand properly. This doesn't obviously cover everything, but it covers a lot of them, you know. You need to look about the ability to, if you can't actively flex or extend a finger, there's a very good chance that there's a tendon injury. You can look at the resting position and the posture of the hand and the digital cascade. We'll kind of talk about that. Obviously look at the skin integrity to see if there's a tendon injury, and look for traumatic arthrotomies into the joint. You know, passive wrist flexion extension. Even if someone hurt, you take their hand, you take someone's hand and you bend it, their fingers will straighten, and if you extend it, their fingers will flex. So you can do that on someone. You're not making them do anything actively, but if the tendons are attached, you actually get some passive flexion and extension of the hand. It's a really good way to test them, and even if you think they tore something, you can still do that. It's just a good start. So with the tenodesis effect, if you move it and everything bends and one sticks straight, or the same way everything else goes straight and one's still bent, then you know that potentially something is torn. The neurovascular structures are very in close proximity to the flexor tendons, so you need to look at that. I mean, basically there's a nerve on each side of your finger. Test both of them, because they have light touch sensation on both sides of the finger. If they don't, there's a chance that there's a nerve injury too. Obviously that means they need to be seen more urgently. When we talk about the cascade of the hand, you can see this is that tenodesis effect, and you can see down here that one finger is not flexing with the rest of them. It's abnormal. Also, you can see this is a normal cascade of the fingers. That finger is not matching there properly. Another one here, basically all the fingers should point to the scaphoid. So this is more with fractures, but anytime you're looking at the hand, and it can be a problem. If you look at my hands, I had a break of my finger, and you can see that this one crosses over where that one doesn't. So got missed by a hand surgeon for me too. But it's something you need to be aware of, and if the fingers are not lining up straight, then something needs to be done to get them fixed. The thumb is obviously a very complicated joint that moves in a lot of different directions, and you need to check opposition, flexion, adduction, and extension of the thumb to really be able to rule out that there is no injury there. Some more tests now here. Flexor digitorum profundus. You should really, when you're examining the hand, isolate each joint. Have them flex that one, have them flex this one, have them flex here, the wrist too. You can see how they do. You can hold the joints straight and have them bend that and isolating that so that they can just check the FDP, the FDS. Here's one test. Hold the fingers down, let them bend the other one. You can do that with all of your fingers. There's a good way to test that one as well. Another common injury, the jersey finger. This is a flexor tendon avulsion off of the distal phalanx. You can see where the finger will hang down. It does look somewhat, in some ways, a little bit like a mallet finger, but you can see here, if you bend all the other fingers, they're actually not able to bend that one down. So there's something to kind of be aware of. You just split the finger to allow it to heal, which is a little bit different than the mallet finger here, which is a little bit of a different injury, but it's jersey finger, no active flexion of the DIP. and sometimes you can even palpate it, and these pretty much all require surgical repair with a referral to a hand surgeon. Now that you guys are going to be doing flexor tendon repairs, we'll just kind of talk about it. You know, if there's less than 75% laceration, and they're not triggering, a lot of times they can be treated non-operatively with timing, but if they're more than 75% lacerated, or if there's triggering the tendon, then they need to repair it. What I read, they said 2 weeks is ideal, but I mean, I think most of the hand surgeons like to see them within a week to get them healed, to get them treated early. Dr. Glenn and I, for the most part, do not do flexor tendon repairs. Maybe an extensor tendon repair, but most of them now we're sending just because of how complex they are and all of the therapy and the follow-up for that. Extensor tendons, they're split into all these different zones of injury. Most commonly injured digit is the long finger, and the zone 6 is the most common place to have them cut at. We talked about zone 1 injuries, that's that mallet finger we talked about earlier. Zone 2 is oftentimes from a laceration or a crush injury. 3 leads to a boutonniere deformity, which I have a little slide on that next. And then zone 5 is oftentimes from a fight bite or a sagittal band rupture. If you have forced extension of a flexed digit, it's most common in the long finger. So here's a boutonniere deformity. You can see if you have a tear of the tendon over your middle phalanx, it can lead to this boutonniere deformity of your finger. Sometimes these can be treated non-operatively if you get them right away, and we can splint them, but a lot of them need to have surgical repair. These are zone 5 injuries. They talked about the sagittal band rupture, which is this here. You can see the MRI with the sagittal bands on the side here rupture and allows the tendon to slip over to the side, and they don't work as well. I also wanted to mention these fight bites, something to be aware of. If someone gets punched in the teeth with their finger flexed, the injury's here, but then when you extend their finger, there's a hole there, but there could be a tear in the tendon there. So just something to kind of be aware of. Obviously, there's a lot of complicated antibiotics involved with this as well, but just kind of be aware of that. Fingers are pretty complicated with this whole extensor mechanism and all the different ways that the bands hold and go, and so be wary of these injuries. I want to talk about finger infections. This is some things a lot of the primary care physicians are going to see, and we get these in the clinic quite a bit. So, starting with the paronychia, this is an infection of the nail fold. So it's here a lot of times from biting nails. It's common in children from, like I said, from biting fingers, and a lot of times in women. I think that's somewhat to do with more contact with water. People who work in cosmetology can create extra areas of trauma to this. Often common in the thumbs, usually Staph aureus. Can be started with warm soaked oral antibiotics and avoidance of nail biting, but this is for swelling only and no fluctuants. Treat them on augmentin or clindamycin. As they get worse, sometimes you need to do an IND of this, sometimes the nail has to come out. If the nail bed has mobility to it, it kind of volatile, that means there's fluid underneath it. So then they need more treatment. This, and then we'll talk about a felon too. If there's fluctuants in there, if there's pus that needs to be drained, go just watch them. We've had a lot of these come to us where they have a ton of pus in their finger and they've been treated on oral antibiotics. Those paronychias can lead to a felon, which is this. I've seen a number of cases that came in with people's fingers looking like this that have been treated non-operatively with oral antibiotics for quite a while. It's a worse finger injury now going into the pulp of the finger. There's all these vertical septae here that kind of hold things in place, and it can create a lot of problems. Again, a lot of times thumb, right next finger, Staph aureus again, but the big thing is that you get this tissue necrosis, you get an abscess, you get kind of this compartment syndrome and ischemia, and then it affects the blood supply. It can go to the bone eventually, and can cause a lot of problems. But the biggest thing with this is that they need to be lanced. You need to get the pus out. The pus is in there, it creates so much pressure that the oral antibiotics can't get to the infection anyways. There's no blood supply. So these need to be drained right away. I mean, this is maybe out of your guys' purview, but the paronychias, you can put a little scalpel in that and get that pus out in your office. It's not very hard to do, but get the infection out as soon as possible. Don't sit on them. Don't wait until they start looking like this before we get them, because then it's a long time to get them treated. There's another pretty serious one too that kind of is in the same purview. It's called an infection flexor tenosynovitis. Can come from felons or septic joints, but it's an infection that goes along the entire flexor tendon sheath. To treat them, if they're really early, sometimes you can hospital with IV antibiotics, ham embolization, and observation, but most of them need to have this IND of the flexor retinaculum, and make 2 incisions at the distally and proximally and distally, and then we have to rinse out flexor tendon. The canable signs are the important thing to be aware of. So if there's a flex posture of the joint, it's tenderness to belching over that flexor tendon sheath, lots of pain with extension of the joint, and the whole finger is swollen. This is kind of a relative orthopedic emergency. Can cause a lot of problems, tendon ruptures leading to abscesses through the whole hand, sometimes permanent finger stiffness. So these need to be seen soon. If you see something like this, so just kind of be aware of it. I want to talk about a couple of common finger problems too that we see in too, just so you guys kind of know. This is Dupuytren's, which is different from trigger fingers. It's this thick band that happens in the hand and will create flexion of the fingers. I don't know, I put all of the science in here, not that it makes that much difference, but there's these nodules and cords that start, they'll start crossing joints and they'll start pulling the joints down. So I've heard people send to, and they say, oh, they've got a trigger finger and then it's a Dupuytren. So just so you guys know, this is what Dupuytren's looks like. This is a trigger finger. So this is a little nodule that occurs, either a nodule or just swelling that occurs right before the A1 pulley of your finger. There's 5 pulleys in your fingers. You get a little swelling, a little nodule actually, just swelling, and the finger will just trigger, as it talks about. 2 to 3% general population, a lot of diabetics. In females, ring and long fingers are most common, involving the A1 pulley. Can be treated with injections or surgical release of this. We can just make a little incision across the A1 pulley and freeze up the area of constriction, and they actually do pretty well. So pretty easily treated, but that's what trigger finger is. Here's decurve veins, another common one that we see a lot of times involved in the EPB and the APL. You get swelling underneath this retinaculum. Is kind of like a trigger finger of the wrist, more or less. Biggest thing is this Finkelstein's test. Put their thumb into their hand and have them flex their hand down. And if you do a Finkelstein's test on someone who's got decurve veins, the result is usually pretty dramatic. It hurts a lot if you do that. So easy way to diagnose that. We can do injections, bracing. There is a little surgery for that again to release this little slip if needed, but we do that uncommonly. Another picture of that Finkelstein maneuver.
What will happen if they do that?
It'll hurt. You put their finger in their hand and have them come down, they'll like jump off the table almost. It hurts so much. It's pretty diagnostic of that decurve. It's pretty easy to treat. So if they come in with pain and swelling kind of over their thumb, try that. Put your thumb in your hand and just flex your wrist down. And if they say, oh, that hurts like crazy, then pretty diagnostic. So kind of a summary. I know I talk fast. They're important. They're harder to diagnose, harder to treat, so be diligent with them. Don't delay treatment. Tendon repairs need to be done urgently. Open wounds, this is something we had trouble with too, where they talked about a delay. Someone was seen and they said, well, I think they need to have delayed closure. Delayed closure of a finger usually means many, many weeks spent with our wound care clinic, slowly healing the fracture by secondary tension. So if you see someone and think someone needs to be repaired, it should be repaired the day it was done. Don't wait on them. Antibiotics within an hour on open fractures. Other thing too is don't send infections, like I said before. If there's fluctuance, if there's abscess, it needs to be drained. I can't think of a time where an abscess was properly treated with oral antibiotics. They need to be drained, need to get the pus out so that we can get the antibiotics to the wound. Test all function of the finger, rule out tendon injury, so be diligent with that. And if you look at them and you're just not sure, don't say there's no tendon injury and send them home. Send them to us if you don't feel comfortable with your exam, so that we can look at it properly. Biggest thing too about the fractures, splint fractures properly. You need to extend it one joint above and below the injury. So if it's a finger, that means just cover the whole finger. You can get a little bit of flexion in the fingers. It'll help. Through the metacarpals, fingers can be straight. But try to splint them properly before you send them to us. We have 6 orthopedic providers. Call us for questions. We might not need to see them that day, but at least you can call us. We can look at something and give you some advice about that. One more thing, Aaron asked me to talk about animal bites, which I forgot to put that in there. There's a really good site called Ortho Bullets. If you have ortho questions about just about anything under the sun, it's in here. They're kind of in a bullet format, and it's a really great way to get things. So the biggest things to know about animal bites is that basically dog bites are more common, cat bites are not quite as common, and humans are third. The biggest thing with dog bites is that a lot of times they cause a lot of crush, puncture, avulsion, and tears. Dogs' jaws are pretty strong, so they can cause a lot of secondary damage, more likely to cause structural damage. Cat bites, very sharp teeth, They're really good at penetrating joints and flexor tendons. This is gonna be one way to get that flexor tenosynovitis we talked about. So with cat bites are actually a higher risk of deep infections than dog bites because they can push the bacteria in a lot deeper. A lot of trouble with bacterial infections with them. You know, Pasteurella is a pretty common one, especially with dogs and cats. So to be aware of that one. Obviously, rabies is something to keep in mind too. You know, a lot of washing out, tetanus. At least one that they put in here. Amoxicillin is a good way to start because it's pretty effective against Pasteurella, which is the most very common one. Cefuroxime and ceftriaxone are good ones too. And a lot of times, sometimes if you need surgical debridement depending upon it. So that's kind of the big things. The crush from a dog bite, more puncture injury from a cat bite, get them on proper antibiotics right away. I guess that's all I have now. So what questions do you guys have? I know I kind of went through that quick. Birth pictures are kind of attention deficit, so they talk too fast.
So with that mallet finger thing, and you put that splint on, are they never, ever, ever allowed to remove it, wash their hands, or?
So what they should do is you tell them, lay your hand flat on something, take that off, wash your hand, do what you need to do, dry it flat, put it back on again, take it back down. So just do not bend the finger because you can tear apart the healing. But if they're diligent with that, usually they heal pretty well and don't have a lot of long-term sequelae from it.
You usually put tape over that to keep it?
Yep.
Because
We
I
have
saw
those
that
in there,
picture,
you
you
put it
just
in there,
slid the finger in
you slide
there.
the finger in, then a piece of tape goes over it, and we just send them home with some tape. And then it's nice because they can still bend here,
Right.
but it keeps that just straight, allows it to heal. All right. Well,
Don't come in here at the end.
thank you guys.
Yeah.
Thanks, Chris.